Welcome back to this discussion of drugs affecting the cardiovascular system. We've looked at drugs used in treating hypertension, but some of these were also useful in treating congestive cardiac failure. We saw this was true of the diuretics that target the edema, and certain of the beta blockers were useful in treating congestive cardiac failure, one particular one that doesn't then induce arrhythmias. There were other ones, sotalol, that were useful in treating arrhythmias. They also affected conduction velocity in the heart, but were indicated for arrhythmias, whereas sotalol was not indicated in congestive cardiac failure. And largely most of the beta blockers that were used in treating hypertension are only used for those disorders and would induce too many arrhythmias because of the effect on conduction velocity, so not useful in treating arrhythmias, not useful in congestive cardiac failure. We'll now go on and have a look at a few more drugs that are useful in treating arrhythmias or congestive cardiac failure. But the other important cardiovascular disease that you will come across in your clientele more than likely will be all forms of angina. So we'll then look at the use of anti-anginal drugs, where once again you'll see some of the same chemical classes and drug names being used. Previously we looked at ischemic heart disease, and then in your concurrent studies or studies that you may have done in the past, you would have studied ischemia, where there is a lessened blood supply to a particular tissue, and then this leads to lack of oxygen, metabolic changes, and other adaptation responses in that tissue to that ischemic condition. And in the heart, it leads to certain diseases that come under the banner of ischemic heart disease. Anywhere where there is an imbalance between the myocardial oxygen demand of the heart tissues and the myocardial oxygen supply from those coronary blood vessels. And so we look at these two aspects of oxygen demand, oxygen supply, as we look at various Western pharmaceuticals that treat angina, a disorder where there is this imbalance, a type of ischemic heart disease. So oxygen demand we'll see is largely determined by the heart rate, but in addition the contractility and the tension that already exists in the left ventricle. The supply, as we said, is largely determined by the blood flow through those coronary vessels. This then delivers arterial oxygen content to those myocardial cells, enabling them to do their vital, life-sustaining job. Whereas if those coronary vessels are not patent, the lumen is in any way compromised, then that will decrease the blood flow. And so you see many manifestations of ischemic heart disease. It's not just angina, and there are many forms of angina. There's stable angina, unstable angina that might be degenerating, Prinz-Metals angina, a particular form, silent myocardial ischemia, right through to myocardial infarct. And then there may be acute coronary insufficiency causing ischemic damage to heart cells. But the commonest that you're going to come across in clinic will be angina, so we will look at the anti-anginal drugs particularly, and the Western pharmacy to control it. The clinical symptoms of angina you have studied previously, we want you to review, or you are concurrently studying it. You'll see your clients experiencing chest pain, which they may describe as radiating. It may make them feel as if their vital life force is draining. It'll be discomfort, perhaps, and this feeling of pressure. They may even describe something sitting on their chest. This will indicate a transient deficiency in the supply of oxygen to the heart. So oftentimes when the stressful event or the exertion is over, then that crushing pain or that feeling of draining life force will go away. Oftentimes this transient block in oxygen supply is because of hardening of the arteries due to fatty plaques. So hardening of the arteries is arteriosclerosis due to many causes, and when it's due to fatty plaques, that's called atherosclerosis particularly, and when it causes angina, it's atherosclerosis of the coronary arteries. So this atherosclerotic chronic changes can go on in other arteries in the body other than the coronary arteries. Angina in the heart occurs due to many triggers, but the one commonality is always then that oxygen demand by those heart muscles will not be met by the supply from the coronary vessels. The pain that is caused is because of the ischemia, leading to metabolic changes and hypoxic metabolites, metabolic acids that build up, stimulate nociceptors and actually contribute to the necrosis and the damage. But it's important to note with angina that these effects are then reversible and that there is no permanent loss of function of those muscle cells in the heart. But if the angina continues and becomes unstable, then the risk of a myocardial infarct or a heart attack and permanent irreversible damage becomes more likely. So we want to treat this angina. Goals of therapy will, of course, to be addressing those risk factors, where integrative medicine and the involvement of a natural healer at helping control stress and tension, introducing more exercise as a regular part of a person's day, better sleep habits, better diet, cutting out smoking, reducing drinking, weight loss, all of those wonderful contributory effects that address the risk factors and reduce the risk of a whole variety of other cardiovascular diseases. But with Western pharmacy, we want to treat the symptoms of the acute attack, so the pain, returning oxygen supply so it meets demand, even in those situations of exertion or other trigger factors. So the person might take a therapy prior to doing their normal exercise routine, or at work when there may be stressful work loads and known upcoming trigger factors. We also want to reduce the frequency and severity of the attacks, because this will reduce the progression to an unstable angina and then perhaps totally reduce the risk of that myocardial infarct. So we'll see that these anti-anginals are prophylactic, preventative drug measures. So there may have already been an event or subsequent vascular events, and we might have a secondary prophylactic treatment to prevent any further changes. And as we indicated, improved prognosis for this person long term, less likelihood that they will contribute to the really worrying mortality figures with ischemic heart diseases, and preventing any further myocardial infarcts or preventing progression to MI, myocardial infarct. So the aim of treatment, we want to use the least amount of drug treatment possible just to abort the attack, return the person to normal functioning. They can then continue with their integrative medicine strategies and their work with their natural healer at controlling stress and other lifestyle factors. Usually the majority, 9 in 10, of acute angina attacks are aborted within 3 to 15 minutes of the use of Western pharmaceutical treatments. The commonest, a short-acting sublingual nitrate. So it would be introduced under the tongue. It then is bypassing first-pass metabolism. The person is not swallowing this nitrate and relying then on absorption. It is directly entering the systemic circulation, where it then can rapidly and readily affect the coronary vessels, hence why that quick response time of sometimes in some cases 3 minutes. So the nitrate that might be used, glycerol trinitrate, but the person might also then be on tablets, a brand name that we've given there, once again, that you may know people who are on this therapy. You may want to investigate it further. There are tablets of isosorbide dinitrate as well, as sprays that are also used sublingually, and we've given a brand name of one of the sublingual sprays. You may know a person who takes that kind of therapy to get that quick, short abortion of an attack of angina to block those oncoming symptoms. The person takes the sublingual spray as needed, so that's PRN using the Latin abbreviation. It's when they feel the pain or just before they might engage in activities that they know are trigger factors. It's only often the stable angina where there is minimal pain and where prophylaxis is showing that there is still some effectiveness, some benefits for that person. Other things that might be used in a chronic stable angina, beta blockers. We also saw that calcium channel blockers might be used. Other nitrates and drugs that are called potassium channel openers, nicorandil. We'll have a look at one of these shortly. So first of all, the use of beta blockers in angina, once again stressing that it's often just a stable angina. These are the drugs that end in olol. We looked at atenolol, which had other indications, but ones like metoprolol and propranolol, propranolol being the prototype beta blocker that are still used and are quite beneficial in stable angina. And once again, we've given some brand names there and some common treatment regimens in case you want to then investigate further because you know people in your clientele or your group of family or friends who might be on these beta blockers. So you know this mechanism of action. Put it again in your drug diary, this next indication for this same class of drug, that because they work at beta-1 receptors in the heart, they inhibit that sympathetic stimulation, blocking at the postganglionic synapse and blocking the actions of noradrenaline, the neurotransmitter, or adrenaline, the hormone that acts at these same receptors. Because it blocks at beta-1 receptors, this will reduce systolic pressure. We saw that beta blockers were used in treatment of hypertension. But this drop in systolic pressure will also then contribute to re-establishing the imbalance between oxygen demand and oxygen supply. Beta blockers we also saw reduce heart rate and contractility, having those effects on cardiac output. And then this will also have those beneficial effects on oxygen demand. You'll get better perfusion of tissues, and whatever the trigger, usually exercise, the pain will be prevented, or an acute attack of the pain will be aborted with the use of the beta blockers. Note that beta blockers don't have any effect on myocardial oxygen supply. They're not working this time at the blood vessels because those coronary blood vessels are defective more in the lumen than in their ability to vasodilate or vasoconstrict. A warning with beta blockers that if a person is unresponsive or if their condition changes, they are not immediately withdrawn from these beta blockers, you may be assisting in that very important patient education, talking the client through titration, slowly reducing the dose over time, a titration, rather than instant withdrawal, because this may actually induce angina symptoms, could actually take a changing and degenerating condition through to myocardial infarct in some cases. So then there was the nitrates that are used prophylactically and to abort acute attacks of angina pain. We saw the sublingual ones available in a range of chemicals and formulations. So glycerol trinitrite, isosorbide dinitrate, glycerol trinitrate, nitrolingual pump spray, and various other formulations. But there were oral nitrates. Isosorbide dinitrate is also available in this tablet formulation. Isosorbide mononitrite also available orally, and glycerol trinitrate also available orally. Then there are transdermal patches, nitroglycerin, glycerol trinitrate, and others that might be used intravenously for a person who is experiencing worsening angina pain, requiring paramedics or requiring emergency department treatment, and glycerol trinitrate is available in these formulations. The mechanism of action is direct at the blood vessels, particularly the coronary blood vessels, as potent vasodilators. You saw that when you exercise, you produce nitrogen monoxide, a potent vasodilator, and it was picked up by hemoglobin and moved away to the lungs where it's breathed out, or it might be metabolized away to nitrates and removed. So these nitrates have similar physiological actions. They work at peripheral veins, arteries, and arterioles, but in angina we're looking at their actions at the coronary vessels. They do react with sulfhydryl groups on the tissues and do increase the release of the free radical nitrogen monoxide, also called nitric oxide, from amino acids in those endothelial cells. And so it was arginine, one particular amino acid, that is then affected when sulfhydryl groups activating certain enzymes cause that change in that production of nitrogen monoxide. So it's the nitrate and the nitrogen monoxide that then contribute to the vasodilation in veins, of venodilation, and this occurs even with very low doses of the nitrates, and just by dilating the veins alone affects the preload amount of blood that's returning to the heart, but will then also at higher doses lead to an arteriodilation, and that will reduce the afterload, the amount of blood that is then outputted to the tissues on the arterial side. All in all, that reduced preload at low doses and reduced afterload on the heart at higher doses of those nitrates will reduce cardiac output. As you saw, this will then have a beneficial effect where the muscle cells then don't have as much oxygen demand because they are not having to produce such a high cardiac output. But you also saw that that will have beneficial effects on blood pressure. There will also be that reduced arterial blood pressure. But if you can explain that nitrates do affect myocardial oxygen demand, decreasing that demand. So here's a summary flow chart of the actions of the nitrates as those vasodilators. First of all, they have to be absorbed. They may be taken orally or they may be taken sublingually as a spray. If they're taken orally, they will be subject to first-pass metabolism. If taken as a spray, you'll get immediate uptake into the systemic circulation and a shorter onset of action in case of an acute attack, where they will then affect vascular smooth muscle. They affect sulfhydryl groups. These sulfhydryl groups are ways of controlling protein actions, and once the nitrate has affected these sulfhydryl groups, you might then get enzymes that are activated to convert arginine into nitric oxide, also known as nitrogen monoxide. That's the active substance. The drug causes the release of that nitric oxide. So some of the enzymes that might be activated when their sulfhydryl groups are affected: guanylate cyclase, which produces cyclic GTP, a secondary messenger, an internal messenger, leading to greater levels of cyclic GMP, reducing intracellular calcium levels, and therefore, because there is less calcium entering those smooth muscle cells, the amount of contraction that you get is less. You get a vasodilatory action. So make sure you can explain at all levels of the cell where those nitrates are having actions on smooth muscles. So because it is affecting a variety of receptors and a secondary messenger, there are ways that you can then alter the levels of those proteins. Because of this, with nitrates, some people can develop tolerance with continual exposure. Sometimes it's the sulfhydryl containing proteins or the secondary messengers that become adapted and changed, and so now you don't get a response to those nitrates anymore. You get a tachyphylaxis. Remember that term, tolerance, often due to changes in receptor amounts. This is with both oral and transdermal long-acting preparations, and all you have to do is take the person off the nitrate, have a nitrate-free interval, and then responsiveness at those sulfhydryl containing receptors or at the secondary messenger proteins, you get a return to normal levels, and then the tachyphylaxis is overcome. So responsiveness then returns to normal. The person then can then go on taking that as a prophylactic for their angina pain. Note that it is less likely to occur with sublingual sprays, where they're only used to abort acute attacks, because you take these as required, and so you don't tend to develop the tolerance. Nitrates do interact with a whole variety of other substances. They should be avoided. A person should avoid taking alcohol if they are on nitrates, and because of actions with vasodilation and production of nitrogen monoxide and other nitrates at the blood vessels, they will interact with antihypertensives. With other vasodilatory substances, you might get a double action of these nitrates causing vasodilation, and this might lead to orthostatic hypotension. Remember, that's the hypotension that a person gets when they change body position. So angina might also be treated with calcium channel blockers. You saw that these calcium channel blockers were useful in treating hypertension by a dual mechanism of action, and similarly in angina they block the channel, less calcium enters, so there is that decreased force of contraction of the smooth muscles. Ultimately, that mechanism alone is sufficient to decrease oxygen demand, but then there is also an effect at systemic arteries, a dilatation at coronary arteries, reduced contractility of cardiac cells, and that also contributes to that decreased oxygen demand. A person might respond quite well to these calcium channel blockers if they have a stable angina. So they might be put on verapamil. It's deemed to be that most potent at the receptors on smooth muscle. So remember, that's the affinity for those receptors. However, verapamil is also the least safe of the calcium channel blockers. You might actually find that the person is on one of the other chemical classes, one of those dihydropyridines such as nifedipine, as an anti-angina preparation. It's short acting, so it's very good for acute attacks, but it could worsen a stable angina, and it could actually induce a tachycardia. Then we saw that rather than targeting calcium channels, that you could open up potassium channels in smooth muscle. The drug was nicorandil. It is a nitrate derivative, but it had a different mechanism of action to other nitrates, having a direct relaxing effect on vascular smooth muscle. But of all the vascular tissues, veins and their vascular tissue is particularly responsive, has a lot of these potassium channels, and then is therefore affected more by this nicorandil. These potassium channels are ATP sensitive, so they're a pump. The potassium being your major intracellular electrolyte, you want to control its levels by pumping it into the cell. We also saw that during contraction, that involves depolarization, moving the potassium out of the cell. But if you open up the potassium channel and keep moving it inside the cell, you get a hyperpolarized state. This then prevents calcium entering, and so it's still working at the actions of calcium at causing the contraction, but using another ion, producing a hyperpolarized state. All in all, you'll get an arterial vasodilation. This is an indirect effect, so once again, two mechanisms, a nitrate derivative effect directly relaxing vascular muscle, and then this indirect effect producing a hyperpolarized state and then making calcium channel action less active at producing a depolarization in those cells. As you can see then from their mechanism of action, they will have many common adverse effects. They'll affect other vessels. They may cause headache, causing spasming at other blood vessels. These headaches tend to be dose dependent, and the headache does actually tend to be transient. But because of effects at other tissues, other veins, there may be facial flushing, and as with most medications, there might be nausea, vomiting, and neurological symptoms, dizziness or weakness. So there were many anti-anginal drugs. We saw beta blockers and calcium channel blockers also used in treating hypertension, but here also used as anti-anginal drugs. Nitrates that worked at blood vessels at producing a vasodilation, a complex mechanism involving increased nitrogen monoxide production and many secondary messengers, where with some of the routes of administration the person could produce tolerance, where they needed a period off the nitrates, where they'd need some other therapy. The calcium channel blockers tended to produce many adverse effects, so one way of overcoming this was nicorandil, the potassium channel opener that had a dual action at blood vessels, a direct nitrate-like effect, but also hyperpolarized smooth muscle, particularly venous smooth muscle.